Welcome everyone to today's Bench2Market talk. Today we have Teresa Wilson, who is the CMS program liaison with Pioneer Next Generation and Shared Savings Accountable Care Organizations. She's going to talk today about Medicare coverage coding and payments. And it's going to be an excellent talk since I've heard this talk before. So Teresa, I will turn it over to you.
Hello, everyone. I'm so glad to be here today. Innovation is my favorite space to be in. In fact, I work with the CMS, the Medicare Innovation Center. So one of the exciting things I've done over the years is work with Georgia Tech and with Emory with a lot of biomedical and clinical engineers on leading edge inventions. And I've developed this particular class to help you write your business plans, do your financial modeling, and decide how you're going to take your creative inventions to market and profit from all of your hard work. So what I'm going to do is go through some slides. It's truly a lot of material to go through, but I'm going to try and cover it in about 45 minutes and leave some time for our questions. And here we go. So the presentation is, I'm going to talk a little bit about the healthcare environment you're going into, how to decide whether it is something that Medicare or insurance could cover, how insurers make those coverage decisions. And the question I'm asked most frequently is, how do I get a code? And we're going to talk about that. And how much will people pay me for my medical device? My coworker is playing. So why are we talking about Medicare? We're talking about Medicare because it's the 600-pound gorilla. Medicare, there are roughly 300 million people in the country, and all private insurance covers 200 million of those. But Medicare is the single largest insurance company in the country, 75 million beneficiaries by the time all the boomers, including me, get into Medicare coverage. And this is the picture of when Medicare was first passed into law, before most of you were born, in 1965. And that's Lyndon Johnson, President Lyndon Johnson, seated at the desk. And of all people, the person who really started the movement towards a national health insurance program for the elderly, the gentleman sitting on the right is President Harry Truman, and standing behind him is his wife, Bess Truman. She was the second Medicare beneficiary. And on the right-hand side of this slide is the actual card that Harry Truman used to sign up for Medicare. So of the 63 million people that are on Medicare today, 13% of them are under age 65. They have disabilities that make them unable to work. And for those that are enrolled, 40% of them on the right-hand side choose some sort of managed care instead of the a la carte fee-for-service. You go wherever you want, you pay 20%, Medicare pays 80%. But 40% of those choose managed care, which is it restricts your ability to go to certain providers. There's certain medical review and utilization review incorporated in it. But it's a growing segment of our market because it really saves money for the patients. It limits their out-of-pocket costs. As you do your research into Medicare, I cannot tell you a more productive website to use than this one, data.cms.gov. We put out what we call public use files that are rich in data, down to the details of the most recent COVID and hospitalization cases. We will also give you information on individual doctors and tell you how much they bill, what codes they bill, what are their average charges. But there's information in here on a variety of topics. Anything that you're researching in the field of healthcare, there will be something at this website. So let me start by telling you a little bit about Medicare law and how government operates. So when Congress wrote the Medicare law, just as when you outline a term paper for college, you start with subpart A, subpart B, and that's why we call Medicare Part A, or anything to do with inpatient care, Part A of Medicare. It was simply the first part of the law that they wrote. Therefore, the second section that they got to had to do with everything else other than hospital care or inpatient nursing home care. It was outpatient care, physician care, ambulances, and where you most often come involved with durable medical equipment, prosthetics, orthotics, and supplies. So Part B of Medicare would include all of those items that are sold individually to patients. If they're provided in a hospital setting, like a pacemaker, that would be covered under Part A of Medicare. And later in the 1970s, we added a managed care component. So Congress went back and added Part C of the law. And in the 1980s, I think that was under President George Bush, we added prescription drug plans. And so we added Part D of Medicare. So there's nothing mysterious about these terms, Part A, Part B. So normally when I teach this class, it's over 3 hours and we do have a lot more time for interaction. But so I like to test your knowledge here at which part of Medicare a medical device could be covered under. We don't have that luxury of time today, so I'm going to skip to the answers. A coronary stent is only implanted in the hospital, so it would be covered under Part A of Medicare for inpatient care. A lab on a chip, the fourth item down, might really be covered in a hospital setting, or it could be covered in a LabCorp or a physician's office. So it could be covered under Part A or Part B, depending on where the lab service is provided. The same would be true of an external catheter. So this applies to not only Medicare, but to any government agency. There is a hierarchy of decision-making. The first and the principal thing that you turn to is the actual law that enacted your program. And for me, for Medicare, Medicare started as an adjunct of the Social Security program. So I always go to the Social Security Act, Title 18. But when Congress writes a law, it's very sketchy. They just give you the broad contours of a program, and they delegate to the agency responsible the role of detailing what they meant. So when they say durable medical equipment, and they mention things, and they say things like an iron lung or a wheelchair, they leave it to an agency like the one I work with to say, well, what are all of the items of durable medical equipment? Or when you say something must be paid for in a certain way, then it falls to an agency to say, how much will we pay for a certain item? Occasionally, an agency will issue formal rulings. And at the lowest hierarchy is something called a policy manual. And these are reams of books, you know, providing the day-to-day operational details about something. So the law may say Medicare will pay for wheelchairs. The regulation will say we will pay for wheelchairs with recliners. We will pay for wheelchairs with footrests. And here are the codes we will pay. And here is how much we will pay. A ruling wouldn't really apply here, but the policy manual will say, oh, and doctor, you must submit your claim on this form using this code, and we will pay it by an electronic deposit this way. So the hierarchy is from top to bottom this way. And here is the important rule from that law that we must pay attention to in Medicare. And it's really critical that you incorporate this into your thinking about your medical devices. No payment may be made for any expense that is not reasonable and necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. What is missing from this is, well, my device is better than what exists. What it is missing from this is, well, my device improves the quality of life for this patient, or other considerations that inventors don't think about. So I will reiterate, it's got to be reasonable and necessary for the treatment of illness or injury or malformed body member. So in the law, this is the citation you may reference if you have to write your business plan. So 1861S of the Social Security Act says that Medicare can cover surgical dressing, splints, casts, devices for fractures and dislocations, durable medical equipment, prosthetics, braces, and so forth. Most of the time, inventors work in this space. And with durable medical equipment, at the time in 1965, iron lungs were still the rage in hospitals. So that's why they're talked about. But it incorporates, 3D printed devices these days. It incorporates transistors, resistors, all of the things that are, wearables. But that's where durable medical equipment falls. So a lot of people come to Medicare and say, I've got my 510K from the FDA, therefore you should pay me. And that's not true. When you go to the FDA, you do your preclinicals and clinicals to show that your device is safe and it is effective. But when it comes to an insurance company, they have to say, well, yeah, it's safe and effective, but is it reasonable and necessary for this patient to treat their illness and injury? So there are two different dynamics here. And to get your medical device paid, you have to fulfill both criteria. And when it comes to the Aetnas or the Humanas or the Optums or United Healthcare, because we have those 75 million patients captive, and because we have the infrastructure to make medical decisions and write medical policies, most insurance companies follow what Medicare says. And they just adopt our policies for their own. So that's why it's important for you to learn how to research and understand Medicare policies. And this is where you go for our commercial and research purposes. So CMS, our Centers for Medicare and Medicaid Services, has two websites about Medicare. This is the one for the agency, and it's the one I recommend that you use. We have another one that you will tell your relatives and parents and grandparents about, and it's Medicare.gov, and that's a consumer site for general questions about Medicare. But when you want to research something, I recommend that you go here and go to the third, fourth, fifth, sixth tab over where it says regulations and guidance. And there you will find something that is called the Internet Only Manuals. And these manuals contain our detailed coverage policies. They will say things like, for a CPAP machine, the patient needs that for these conditions. So you will want to know if there is a policy for your device before you put it into market. And when you go to those internet only manuals, you will see these, the Medicare Benefit Policy Manual and National Coverage Decision Manuals. And you can drill down into those. For example, in the Medicare Benefit Policy Manual, you can look by provider type, medical supplies, ambulance, hospital. And in the National Coverage Decisions, you can search by body system. So when you get to that manual, you'll look at the cardiovascular policies, or you may look at the neuromuscular policies. Whatever body system you're looking at, we will detail our policies by that body system. A third place you can look, and this is a great Boolean search place where you can go to our coverage database, and it will sort of backtrack to some of the references that I've mentioned previously. But you could put in here glucometer, CPAP, hypertension, and it will pull up documents related to that search. And you can filter it and refine your search by states or geography, by the type of document that you want to retrieve. Oh, thank you, Morgan, for chatting those in. One of the things that I enjoy doing in this class is to give you a couple of case studies. And frankly, this next one I have been following for a full 20 years, and I love talking about this particular invention in the context of Medicare. Dean Kamen, who developed this device called the Ibot, and he set a manufacturer's suggested retail price of $25,000 for it 20 years ago. What did Medicare decide when he presented this device to Medicare for payment? I'll give you a chance to think about that definition of what's reasonable and necessary. And then I will add that Dean Kamen, as brilliant as he is, made a strategic error in his marketing. He marketed this device for self-esteem. He marketed it as a quality of life device. And he said people who have mobility problems need to be able to have the dignity to look at their family members or colleagues face to face. They need to be able to walk up steps despite having ramps. They need to be able to go out onto the golf course and play golf with their friends from an upright position. So what Medicare did was say, well, listen, this isn't medically necessary. A person can have an electric wheelchair under Medicare already. You don't need to provide that to your Medicare beneficiaries. We're not going to cover it. And it's now, I want to show you what's happened in the 20 years since then. All right, Morgan, you may have to make sure that this shows properly on screen. Let me know if this is working.
Let me introduce the Ibot PMD. Reach, climb, go. The Ibot personal mobility device, Ibot PMD, opens up a magnet so you can leave the typical market. With its terrain following technology. In the Ibot, you can even climb stairs. Let's unload the Ibot PMD and show you what it can do. You can easily store and transport an Ibot in remote configuration. So you can turn on
Teresa, maybe we can drop the video in the chat as well, because the audio is pretty hard to hear.
this remote environment and enjoy with you. States to reopen in the US. A unique Ibot design includes 4 environments that make sterility possible. Sterility can be so system. Since the Ibot is custom built to live
I see that some of you are having trouble hearing the audio. You'll have slides after my presentation. You can look up all these URLs, or you could just Google Ibot. But one of the things that's been interesting over the 20 years is that he's, Dean Kamen invented the dialysis machine, just so many wonderful inventions, the insulin pump, the wearable insulin pump. And this is something that he says was technologically very difficult to do, and he wants to see it go to market. He has partnered with Toyota, and that went nowhere. He's now partnering with another company, and I'll watch it until it somehow makes it to market. It's an interesting product. I think it has value for patients, and we'll see where it goes in the future. So now I want to talk a little bit about coding. And this is probably not the most scintillating part of my talk, but everything that we do in Medicare is done electronically. We never see paper when somebody goes to a doctor or to a hospital. The claims are sent to us electronically. We transact them overnight. We issue direct deposits, and everything is, we tell the medical providers what we've done electronically. The only thing that is in paper is we send the patients what amounts to a credit card statement each quarter, telling them what we've paid on their behalf. But they're coding conventions. So when you're billing in the hospital, you bill a diagnosis related group. When you bill under Part A and Part B of Medicare, you use the HCFA Common Procedure Coding System, which is called HCPCS, which includes within it the common procedure terminology codes developed by the American Medical Association, codes that AMA has no reason to use, like dental codes, drug codes, and there level codes where we might need to put in a temporary code, like for all the COVID testing and COVID injections that we've had to do over the last year. When you talk about how a person is diagnosed, their illness, their social determinants of health, we look for the International Classification of Diseases, which is put out by the World Health Organization. But everything has a code, the place of service, the specialty of the provider, everything works off bits and digits. So a sample diagnosis related group might be for a gallbladder removal. So you might think, well, there's only one type of gallbladder removal, but there's really not. It can be open with an incision. It can be closed with a laparoscope. It can have complications. They may need to take out an extra organ. It can have complications and comorbidities. So there are all of these ways to give you a finite picture of why a person was in the hospital. And for diagnosis codes, the US version, once the World Health Organization puts out a master list, each country has to create their own personalized version. And the US version has 76,000 codes that follow this nomenclature. And I tell you, I don't want to protract this discussion except to show you 3 of my very favorite ICD codes. You can have an ironing accident and go to the emergency department for that. You can be bitten by a cow and have to go and get some stitches. And I guess you could go to a psychiatrist if you have a problem in relationship with your in-laws. But however you have an illness or diagnosis or injury, we get it through a widget, through a digit. So this is the question most inventors ask me: how do I get my code? And the answer to that is, in the overwhelming number of cases, you don't need one. And so the question you ask yourself as an inventor is, are you selling to the provider or are you selling to the patient? And that's where you start your personal inventory of whether you need a billing code or not. So typical customers include patients. Now, you might sell them a medical device like a Band-Aid, a simple level 1, category 1, 510K Band-Aid, and you may sell that over the counter. But if you're selling them crutches, you may sell them that and it be covered under insurance where a Band-Aid wouldn't be. You can sell your device. It might be a wearable that alerts doctors of a patient's biometric that's out of bounds. That could be something you sell to a doctor that the doctor leases to the patient or sells to the patient. You could sell it to institutions like rehab facilities, Shepherd Spinal Center here in Atlanta, or you could sell it to a skilled nursing facility, a hospital. You might really have a key opinion leader as your customer, particularly when I've been involved in clinical trials globally. We involved key opinion leaders at leading institutions around the world where that physician was an expert in a particular type of surgery. And so you may be selling to that key opinion leader or her or his institution. Oftentimes you're selling not to a clinician, but to the chief financial officer. And your business case is that my device is a little bit more expensive, but it's a lot better. And it will allow you to turn your operating suite one extra time per day, giving your hospital more revenue. So the chief financial officer is a key customer of yours. You might be selling to a managed care organization that's focused on utilization review and cutting costs, or you might be selling to the newly emerging type of organization and the kind that I work with, which is a value-based care organization where they are trying to save costs while they are improving patient health. So if you are selling to a hospital, to a group purchasing organization, to a someone who is outside of the insurance world, you probably need a UPC or a barcode, and you don't need a descriptor code. A pacemaker, for example, as I said, is only implanted in the hospital. You don't need a code for that. You're selling to the hospital. That pacemaker is never going to be on an insurance form. It's going to be billed, incorporated into a diagnosis related group in the same way that a surgical curette or a surgical tray is going to be part of a diagnosis related group. So the chances, in fact, in 7 years of teaching this class, I've only encountered one medical device that was unique enough that it required a significantly different code than already existed. And the reason that you want to try and shoehorn your device into an existing code is that it takes up to 2 years for you to justify a new code to any insurance company. And the reason is it's expensive for us to add a new code. It has to be published in a federal regulation. It has to be migrated to more than 50 computer systems. We have to develop a fee schedule by convening medical panels to set fees. And one of the criteria for us to approve a new code is that there must be enough market demand to justify that expense. So until you have sales, you are not going to get a new code from CMS for you to do billing. So the answer is to find a way to get revenue in the meantime, either through direct sales, group purchasing organization sales, Medicare Advantage or managed care sales, so that you don't have a cash flow issue while you may be waiting for a code. So how do you know what a company is going to pay for your device? This is a very simplified version. A patient goes to a healthcare provider. A provider sends a claim electronically to a Medicare administrative contractor. These are transaction companies, usually in subsidiaries of other insurance companies that process claims for us at our direction on our software. And then they adjudicate the claims, and then they send the payment back to the doctor. They also generate what look like credit card statements that go to the patients to tell them what we've paid on their behalf. So again, how do you get paid? You figure out who your customer is. So you can go to, if you have a device, larger organizations, and I dare say Emory Healthcare, the Piedmont Healthcare, you know, WellCare, WellStar, they all go to a network, a group purchasing organization. They may go to Health Trust or Premier or some of the other GPOs. The system usually centralizes its purchasing. And so you may not need a unique code other than a barcode or a UPC to sell that. Over the last 2 years, 3 years, I found that most of the inventions that I've been dealing with from these classes have to do with remote patient monitoring, and they are biometric devices. And so you may not want to put your device in market. You may want to sell it or lease it to an aggregator or a company like Vivify that aggregates or provides all sorts of remote patient monitoring devices, from scales to glucometers that speak to, you know, whatever device, dialysis monitors. And you may want to just sell or lease your device and have an exit for your particular device with a license or some sort of annual payment. And don't forget that cities, states, federal government, the VA, the Veterans Administration, the Department of Defense, and Native American tribal governments, those contracts can be very lucrative. And if you go and in the area of prosthetics, for example, there is no one more advanced than the U.S. Department, the Veterans Administration Department. They have the most interesting robotics and prosthetics. And so getting on their list for a device in that field might gain you traction, market credibility, and give you the basis for requesting your own HCPCS code. But tribal governments also have very lucrative contracts, as does the Department of Defense, particularly if you've got something that has battlefield or readiness capability. So those are very lucrative places to look to market your device. So terminology you might hear is, and don't let them be off-putting. They're really simple beneath the terms. Prospective payment system means that we pay hospitals an average of what it costs to treat something. And then once a year, we audit the hospital's cost reports and we square things up. So in the example I gave you earlier of a gallbladder removal, we might say on average, when a patient goes to a hospital, we pay $5,000 for everything that the hospital does for a gallbladder removal. And that includes the use of the rooms, the surgical suite, the nursing staff, the on-hospital physician staff, the surgical kits, drapes, bandages. And so we'll pay upfront $5,000 per case. prospectively pay that. And then at the end of the year, we will square up with the hospital for their actual costs. And so the following year, instead of 5,000, we might pay 4,950 or 5,100. But when we pay things prospectively, it's on an average. When it's on a fee schedule, it's things like wheels, chairs, crutches, glucometers. We pay on a per device basis. So you will want to be able to look up these fee schedules to plug into your financial projections. You may want to say in the Atlanta market, we know that there are 400,000 Medicare beneficiaries. We know that 25% of them have diabetes. We know that they all need a glucometer, and we think of those 5% are going to adapt to our brand new technology because it's better, faster, cheaper. And so what Medicare pays for a glucometer is X, and therefore we expect our first year revenue to be Y. That's why I think it's important for you to know how to look up fee schedules. So here's the site, and this will be in the PowerPoint that is shared with you. This URL will take you, excuse me, to the CMS site that will link you to every fee schedule. And if you're working in the Southeast, these are the company names that you will see. You will see Palmetto GBA, which is a company that does work. They're based in South Carolina, and it's really a subsidiary of Blue Cross and Blue Shield of South Carolina. They will do services in Alabama, Georgia, and Tennessee. Excuse me. First Coast Service Options, or FIXO, is a subsidiary of Blue Cross and Blue Shield of Florida, and they will handle the payments in that state. Connecticut General Services, in the middle on the bottom, is a subsidiary of our CGS of Connecticut General Life Insurance. I think they're based in Connecticut, but they have an office in Nashville that handles all of the medical devices and prosthetics for a quarter of the country, including the state of Georgia. Now, here's what I do. The fee schedule from state to state can vary by 10 cents or $1. But when I'm doing a financial estimate, I don't need to get down to the dime or the nickel. I need a rule of thumb. So on this next page, I'll tell you whatever state I'm dealing with, from Wyoming to Vermont, I always go to Palmetto if it's a professional service, and I always go to CGS if it's a prosthetic or a piece of medical equipment. The fees are not that different. And so I'm going to walk you through how we might look these up. So I'm going to look for a transurethral resection of the prostate, 52601, done in Atlanta this year. So I'm going to go to Palmetto. Go to Palmetto. I'm going to look in Georgia. I am going to do 52601, and I'm going to just do a quick search. Make sure I probably didn't select a date. Let me make sure. Georgia, 22, oh, that's what I didn't do. I didn't select the date, 22. I'm not seeing the drop down. Display 526 effective date. All. I'm not seeing what did I type the wrong number? Well, it never fails when you try and show something on screen. Carry location, display up to 5 fields. I don't see where I've made an error here, but clearly I have. But I assure you, oh, that's what I did. I think that's it, 52601. There it is. So I was transposing numbers. So for this particular surgery, in January, starting January 22, Medicare pays $731 to a surgeon performing prostate surgery. And that is how easy it is to look up. And I guarantee you're not going to have the same kind of trouble I had when you look, when you try and do this. So the next thing that I want to show you, and here's the screenshot of that. So the next thing I want to show is how you look up a prosthetic or a medical device. And EO601 is a CPAP machine, and I'm going to do the same with CGS. So I'm going to look up Georgia, I'm going to look up 2022, and I'm going to look up EO601, and I'll show you that will pay. So what that pays is $62.34, and that is on a rental basis. So every CPAP you see, Medicare is, that's for a Medicare beneficiary, we're paying $62 for that. And over to the side, you may note if a person is 50 miles from an urban area, we pay a rural add-on, and that's because the delivery is kind of expensive to patients in rural areas. I'm going to go through a few more real quick. This is another case study, and it occurred at Georgia Tech. Partha Unava had a broken ankle. His crutches hurt his arm, so he decided to develop some better crutches. And I want to show you, and he decided he could sell them for $99.99. This was back in 2015. And I'm going to share this video, and the URL, if the audio isn't clear, is going to be in your slide.
Each year, hundreds of thousands of Americans find themselves hobbling around on crutches. When Partha Unava broke his ankle playing basketball, he spent 6 weeks trying to get around on those familiar sticks.
That's when I realized that crutches are one of the worst things happening.
Instead of getting frustrated, the Georgia Tech engineering student got to work on designing a better product.
I think my life has kind of been around the let's make lemonade. Remedy always better crutches.
Unava spent a year researching the crutch and the history of its design.
And at that point, we thought, okay, this is a problem that's existed for thousands of years. Even pharaohs had another pain that we experience. It's about time something to change.
Over the decades, many varieties of crutches have emerged, from arm cuffs to hands-free platform devices. So there are a fair share of competitors. But Unava says his crutch has unique blending designs that helps eliminate underarm pain and nerve damage in a whole new way.
So the key features of the Bench2Market crutch, it really starts with this forearm support. So when you lay your forearm on here, you have a lot more contact area, which means you have a better weight distribution through that. And the wrist center, because our arms at an angle, a lot of force goes directly through our wrist. It's split between your forearm and your hand. So it's a lot better support. And finally, when you go to rest on this crutch, because you're putting force down on the forearm support, this side piece ends up pushing into your body rather than up in your armpit.
He has turned this concept into a company called Better Walk, and it's definitely getting the 22-year-old CEO noticed. As a rising young entrepreneur, he's demonstrated his crutch to President Obama and has made it on Forbes' prestigious 30 Under 30 list. Unava attributes his company's success to the valuable input and feedback he's received from the medical community.
Our philosophy is that the best people to design a product are the ones that use it or whose patients use it. So we went straight to orthopedic surgeons, physical therapists, and their patients. And I think we had about 100 of them involved in the process, where every iteration we took back out, they tried it out, they gave us feedback, and we did that over and over until we got to a point where they were ready to go.
Unava plans to roll out his first few thousand units this summer through select hospitals. The Better Walk crutch will retail at $130 versus the traditional crutch that costs about $55. Given the choices, people will have to decide.
Our goal since day one has been to change the standard of care. That's something I still 100% believe that we're going to do.
So if any of you have had to wear crutches for any amount of time, I'm sure you can understand that Partha's design was better, but it was a flop. And why? Because it was better, faster, but it was not cheaper. And here is the reason it failed. Medicare pays for crutches, but Medicare only pays $49 today for crutches. And he couldn't sell it to Medicare patients because they had to pay the difference out of pocket. And because Medicare wouldn't provide another code, because the feature of being more comfortable was not medically necessary, going back to that original definition. So I've run about 5 minutes over. We have 10 minutes for Q&A, but I do want to provide you my contact information. And I've worked with teams over these past few years. If you're working with a team and want to set up a call, I'd be happy to talk with you and offer you some advice on marketing your device or how to help write your business plan or a feature of your business plan. And I enjoy doing that because I learned from all of you about what's new and what's in the future for healthcare. And that's an exciting field for me. As we were setting up for this presentation, it occurred, my audio went out so that I cannot hear you. So I have to tell you, if you have some questions, you either have to chat them in or send them to the Q&A section. And I'll be glad to take questions until Morgan tells me it's time to end. Would you be able to share more about recent digital health RPM trends? For example, digital health and data-driven codes. There are two things that I'll share with you that are really important for inventors. Doctors may be paid for a code that's called remote patient monitoring. If they spend 30 to 60 minutes a month monitoring biometrics of their patients. So many of you are creating the devices that make that possible. So what you may want to do is you don't need to sell to those patients. What you need to do is either sell to those doctors or to that a type of aggregator who sells remote patient monitoring devices so that you enable the doctor to bill, but your revenue is based on that doctor loaning, leasing, or selling your devices directly to patients. And oftentimes, you know, like in the old Holter monitor example, a doctor would own Holter monitors, give them to the patient, and Medicare would pay the doctor for interpreting Holter monitors over a month, 30-day period. So you need to get into thinking about that way of generating revenue. And in the space that I work, which is value-based space or accountable care organizations or anything that is the new and emerging type of healthcare delivery system, they're definitely interested in population level dynamics. So they categorize their patients, and they may be looking at 100,000 patients at a time in a population health AI platform. And what they categorize patients as chronically ill, healthy, rising risk. And they want to focus in on those people with the rising risk because they have the potential for being the most expensive. Conversely, they can save the most money by intervening with those patients. And believe it or not, healthcare AI can say these 10 patients are the ones most likely to be hospitalized in the next 6 months. So you want to do your biometrics so they can do that kind of population health research. Morgan, I think that may be it. And I can't hear you, but
Can't hear me.
But I know you'll close up.
I'm going to ask one more question here in the chat.
when should inventors look into billing as you're developing the device? Because if you're going to sell it, most of you will have to develop a business plan with financial projections. You've got to be realistic about how you're going to get revenue. And with some inventors, you've got to have 2 or more sources of revenue. If you do need a unique HCPCS code, that lead time is 2 years. So you've got to see, where am I going to sell it in the meantime? I'm going to ask Medicare for a code, and I know that's going to take 2 years. So in the interim, I'm going to go after VA contracts because my device works in that field. Or I've already got a lead on a Department of Defense contract because my device works in the battlefield. It helps staunch bleeding with IEDs, or it does something to stabilize the head after an IED. So you have multiple revenue streams while you're waiting for a code. You cannot start that work too quickly if you want some financial compensation.
All right, I guess we'll close it there. Thank you, Teresa, and thank you, everyone. I know you can't hear. Oh, one more question if you want to take that one.
The only 3D device I have seen was brilliant. It was an on-demand 3D patch for a body organ. And it could be customized in site, and the team could prove that it was it could reduce infections, complications. But they were going to create that in a universe, in a limitless number of configurations, but they only needed 1 code.
Any other questions from the audience? All right, we will close it here. Thank you.